And right now, give it one more minute. And I see some people are still coming.
All right.
Well, I'm gonna begin. Well, welcome everyone, and thank you for attending NAPSA's Research to Practice webinar with our guest, Dr. Frank Puga. I'm Esther Thorpe, the Administrative Project Coordinator with NAPSA, and I'll be moderating today's webinar. For those of you who are not aware, NAPSA, or the National Adult Protective Services Association, is a nonprofit membership organization that exists to provide training, advocacy, and networking opportunities for APS workers, allied professionals, victims of abuse, and anyone interested in preventing and raising awareness of elder and adult abuse. Please visit our website, napsa-now.org, to learn more about us and become a member. The webinar today has been organized by NAPSA's Research to Practice Interest Group, which is often referred to as R2P. And R2P is a network of researchers and practitioners across the country who all share an interest in advancing the field of APS and protective services. If you are interested in hearing more about the quarterly webinars, the work that's being done with the APS Administrative Data Initiative, or you love to just have a space to connect with others, there is a group that we encourage you to join, and you can visit our website to learn more and get instructions on how to join. And I will also drop the link in the chat shortly. So just everyone is aware, you all will be muted, and then after the presentation, you can drop any questions in the Q&A box, or you can get off mute if you'd like to ask your question that way. So yeah, I will go ahead and hand it off to our speaker and have him introduce himself.
All right, thank you very much. Let me go ahead and pull up my screen here, make sure we're good to go there. All right, well, hello everyone. I want to thank you all for being here today. My name is Frank Puga. I'm a assistant professor at the University of Alabama at Birmingham School of Nursing. My background is in behavioral neuroscience and psychology, and I have a program of science that's really focused on examining the daily experiences and long-term experiences of people, older adults living with chronic illness and their care partners. I have a specific interest on mental health specifically, and identifying social and cultural factors that may improve resilience over time for people that are undergoing extreme stress related to living with a chronic illness or providing care for an older adult. Today, I'm going to discuss caregiver mental health, which is an increasingly recognized as a dynamic and essential factor in the quality of care provided to older adults. Specifically, I'm going to focus on the impact of daily fluctuations in caregiver mental health and the risk of elder mistreatment and how tracking these changes can potentially mitigate mistreatment risk. So to give you an overview, I've organized this presentation into 4 main sections. First, we'll cover the importance of caregiver mental health and its role in ensuring care quality and safety. Second, we'll discuss how daily mental health variability serves as a risk factor for mistreatment, highlighting why a dynamic approach is crucial. Next, I'll share findings from a daily study on dementia caregiver mental health, which provides a deeper look into how daily stressors and emotional outcomes really are driving a lot of the experiences for caregivers. And finally, we'll examine the implications of these findings, particularly how understanding daily mental health patterns can inform strategies for preventing elder mistreatment. By the end, I hope you'll see how this approach can transform how we support caregivers and reduce risk factors. So to begin, caregiver mental health is not just important for caregivers themselves, but is also critical for the well-being of those they care for. High levels of mental strain in caregivers can impact their patients' energy and empathy, which are crucial for quality caregiving. Now, research shows that caregiving is associated with higher rates of depression, anxiety, and stress, which left unmanaged can lead to burnout and poor coping. I'm going to share some specific data on the mental health burden for caregivers to illustrate the significant impact of these challenges. So more than 20% of the US population is involved in caregiving for a relative, friend, or neighbor. And this number has been growing and has, as more people take on caregiving roles, they often do so without adequate support. There was a recent report from the National Alliance of Caregiving that was put out last year that really highlighted some of the unique mental health risks that caregivers face. And a lot of this is often linked to experiences of intense stress, isolation, and a sense of responsibility for another person's well-being. Now, these factors create a challenging environment that can easily lead to poor mental health outcomes, and high levels of anxiety and depression and stress are common among caregivers, especially those caring for individuals with chronic conditions or disabilities. And when you look at the data on stress, anxiety, and depression, the numbers are quite striking. So we have over 50% of caregivers reporting poor mental health. Now, for a reference, about 17 to 18% of the general population experiences anxiety and depression. So caregivers seem to be at an increased risk of experiencing poor mental health. Further, there are differences based on gender, with female identifying caregivers reporting higher stress, anxiety, and depression symptoms compared to male identifying caregivers. Now, let's break down the primary risk factors affecting caregiver mental health. First, caregiver burden is one of the most significant factors. This burden involves the physical and emotional demands of caregiving, which often lead to exhaustion and stress. Second, social isolation is a major issue, with many caregivers finding their social networks shrinking due to time constraints, which can lead to loneliness and reduced social support. Finally, lack of support, both social and instrumental, compounds these challenges. Without access to resources or help for family, caregivers are left to manage intense responsibilities alone, and this lack of support often results in burnout, which further increases the risk of mistreatment. And recent reports have really underscored the critical role caregiver mental health may play in abuse and neglect risk, with several studies linking caregiver mental health, collected at baseline or cross-sectionally, and showing associations with increased risk for abusive and neglectful behaviors. And, in light of that work, you got me thinking about, a lot of the studies that we currently look at kind of treat mental health as kind of this static experience, right? We do an assessment, we take a PHQ-9, maybe at a doctor's visit, we measure it in research studies every couple of months, 6 months, 12 months, et cetera. But there's growing recognition that caregiver mental health is highly dynamic, meaning it changes frequently, influenced by day-to-day events and stressors. So for instance, a caregiver's mood and mental state may be significantly affected by a bad day at work or an especially challenging day of caregiving. And these types of experiences may not be captured when we do a periodic assessment of mental health every couple of months. And traditional approaches also might overlook these fluctuations, but understanding them is essential for effective intervention. So by tracking these changes, we can capture early indicators of stress and intervene before they escalate into burnout or harmful behaviors. This concept of dynamic mental health shifts our focus to a more real-time understanding of caregivers' needs. Now, there's also emerging perspectives on variability in mental health that could potentially signal a shift from mild symptom experience to more severe psychopathology or even predict harmful behaviors. So essentially, when we look at micro-level or daily patterns of symptoms and mood and affect, these can be used to predict future outcomes in at-risk populations. And to highlight this a little bit more, so historically, when we have static models, they've been used to predict mental health outcomes, assuming that the individual's mental health is relatively stable over time. However, these models often miss subtle changes that could indicate heightened risk. So dynamic models, in contrast, allow us to capture day-to-day fluctuations in mental health, providing a more accurate picture of a caregiver's state. For instance, if a caregiver's stress is consistently high for several days, a dynamic model can alert us to this pattern, suggesting they may need additional support during this period. And recent work supports the importance of this approach, demonstrating that mental health outcomes are better predicted through dynamic tracking. And so what we see in these figures here, if we look, and over time, if we were to do a baseline assessment and say a follow-up assessment 6 months or a year later, we might notice that there's just a dramatic increase, from maybe low depression, let's use as an example, to high depression later on. But we even may have people that have, dips and peaks and valleys throughout the year of experiencing depression and anxiety. However, if we were to do a more granular level investigation and think about this perspective of mental health as dynamic, we could probably see a little bit more fluctuation. So if we go at the day level, we could potentially see some changes over time that are difficult to see if we were just to do assessments at baseline 6 months, 12 months. And so the ability to track day-to-day changes might provide some insight into individual experiences. So a multi-level perspective can really help us understand the smallest building blocks underlying the onset and the course of mental health. Such an approach facilitates an examination of the dynamic interplay between micro-level, moment-to-moment experiences and behavioral patterns over time. So if we break down, instead of just looking for, whether or not somebody is meeting the criteria for clinically significant depression and is exhibiting several symptoms to warrant a diagnosis, we might know that there are probably more granular levels of experience that could underlie these shifts from a casual symptom experience to more clinically significant depression or anxiety. So for example, experiencing minor stress, even affective states, how often a person feels cheerful, and even social factors, whether they're interacting with others, all types of variations in these different areas and domains could potentially signal some potential shifts in one's overall mental health experience and potentially be a key to help us understand when a person might gradually increase or intensify their symptoms and develop a more clinically significant diagnosis of depression or anxiety, or exhibit certain behaviors that could be potentially harmful to themselves or to others. And so one way to capture these day-to-day mental health fluctuations is through intensive longitudinal study designs. This approach, which involves frequent assessments over time, can provide insights into how a caregiver's mental health varies and how these variations may predict caregiving behaviors. These types of designs, which can include things like using daily surveys or using ecological momentary assessments, which are multiple surveys within a day, can help you determine if affective states are linked to contextual factors, and if variability in affective states or symptom experience can be used as an early warning signal for severe psychopathology or harmful behaviors. So as an example, I'm going to discuss one of our studies that employed an intensive longitudinal design to capture daily fluctuations in caregiver mental health. And this design allowed us to collect data in real time through daily diary surveys, which helps provide a window into how caregivers' mental health changes from day to day. And really allows us to focus on a more it allows us to collect more granular level data that we can use to better understand the immediate impacts of stress and identify patterns that static data might miss. Now, our study specifically looked at dementia caregivers who often face heightened mental health challenges due to the nature of dementia care. And dementia caregiving involves managing complex behaviors, which can be stressful and emotionally draining, and can, in literature suggests, can change from day to day. So we aim to see how daily mental health changes related to these challenges with a focus on depression, anxiety, and emotional regulation could potentially serve as a key down the road to allow us to determine when a person might be at risk of engaging in harmful behaviors. So dementia caregivers face a particularly high mental health risk. The rates of depression and anxiety among this group are estimated to be between 34 and 44%. So again, like caregivers of older adults of any chronic illness, we see this increased risk of poor mental health. And additionally, roughly 60% of spousal caregivers for individuals of Alzheimer's disease and related dementias develop significant depression or anxiety within 2 years. So these high rates really reflect the intense demands of caregiving for someone with cognitive decline and reinforcing the need for ongoing support and resources. And again, if you put this into the context in the general population that I mentioned earlier, these estimates are well above the 17 to 18% prevalence estimates in the general population. So caregiving for individuals with dementia involves unique contextual factors. Managing symptoms like memory loss, confusion, and behavioral changes can be incredibly taxing. Caregivers may also face distress from watching their relative's cognitive abilities decline over time, and these added stressors contribute significantly to mental health strain. And without adequate support, they can really result in poor coping strategies. And so we noticed in prior work that a lot of stress and strain that comes from for dementia caregivers, it really stems from the functional decline of the individual living with dementia, the physical demands of caregiving. We often talk about like just the amount of physical strain people experience in terms of whether it's helping their relative get in and out of bed, helping them walk, that can really take a toll on one's body. And then also managing behavioral symptoms of dementia, which can involve things like experiences of hallucination, memory decline, restlessness, wandering, agitation. A lot of these behaviors have been reported to be very distressing for dementia caregivers. So for the study specifically, we developed the risk resilience model of caregiver behaviors and mental health to guide the work that we're doing. And the model is really informed by stress process models and resilience theory, and in starting to incorporate some of a theory that comes out of systems engineering in the field of complex adaptive systems and dynamic systems theory. And I'll get to that in a little bit here. But what I want to really just highlight here is with this type of model, we can really show how factors like stress and isolation alongside coping strategies influence mental health outcomes. So for example, a caregiver with strong emotional regulation skills might be better equipped to handle stress without feeling overwhelmed. Conversely, if stress and social isolation are high and coping resources are limited, this model suggests that there is a higher risk of negative behaviors. So emphasizing the need to bolster resilience through support. These processes can affect daily mental health experiences such as depression and anxiety symptoms, and their patterns over time may eventually influence caregiver behaviors and distal mental health outcomes. And so a lot of the work that I'm doing these days is really focused on understanding these daily experiences and how these risk and protective pathways might either drive or influence these daily experiences and ultimately influence a caregiver's behavioral responses that can drive their mental health outcomes and for resulting either in them developing clinically significant depression and anxiety, or potentially driving them to engage in harmful behaviors towards themselves or others. So to give you a little bit of an overview of what we did in the study, we used daily diary surveys to capture real-time insights into caregiver mental health. These are short surveys that we gave each night to our participants that asked them to reflect on the previous 24 hours, the past 24 hours. And so participants completed these in two waves of data collection. First, participants completed a baseline survey that asked them about their sociodemographic information for themselves and for the person living with dementia, and asked about baseline health and the caregiving context. And then one day after completing the baseline survey, participants completed a series of daily surveys for 14 days. These surveys asked participants about stressors, psychological resources, social support, and mental health experiences in the past 24 hours. And this process was then again repeated 3 months later. Now, there's different variations of this design that you can use, and this was kind of one of our first explorations of this. And so I have larger studies right now that are actually employing similar designs where we're doing 3 assessments at baseline, 6 months, and 12 months. And the daily diary surveys, instead of doing a 14-day, we're doing a 21-day, We found through a lot of our ongoing studies that 14 to 21 days of surveys seems to be a reasonable amount for our caregivers to complete without being overly burdensome, especially since we try to keep the surveys to be about 5 to 10 minutes. And then we found that in terms of follow-ups, doing a baseline, a 6-month and a 12-month allows us to maintain, to minimize attrition over the ways of data collection and allows us to see some changes over time. So this one's a little bit of a shorter time gap between the baseline and 3-month follow-up survey, but it still allows us to detect some changes in some of these preliminary investigations. So we collected data from a sample of community dwelling family caregivers using multiple recruitment strategies, including social media, partnerships with caregiving organizations, and referrals from clinical partners. And we did this to really maximize our ability to reach a wider sample here. So definitely this is convenience sampling, but definitely it allowed us to reach a broader number of caregivers for the study. We are also, wanted to make sure that we were able to engage people that, one, could easily complete the surveys. And so a lot of this, or we try to design the study so that facilitate caregivers easily completing the surveys. And so a lot of this was done online. So data collected, we're using REDCap. And majority of our measures included things like emotional regulation, which was measured using a single item. So for example, when you felt angry or anxious, how often did you lose control over your behaviors? We also measured daily social isolation using the patient-reported outcomes measurement information system, or PROMIS, short form social isolation scale. And this scale consists of 4 items that measure perceptions of social isolation. We also use to measure daily depression and anxiety, we use the PROMIS short form emotional distress depression and the PROMIS short form emotional distress anxiety scales. And we also, since we were looking at depression and anxiety, we were also interested in measuring suicidal ideation, which was measured using 2 items. How often did you think about dying and how often did you think about ending your life? And data were analyzed using multi-level modeling and time-varying models to account for the clustered nature of the data. So this essentially allowed us to examine how daily experiences and long-term trends in mental health affect caregiving behaviors and really helped us understand kind of the ebb and flow of caregiver mental health. We also use the time-varying effect modeling, which is a novel method that enables us to look at health, behavioral, and social factors to examine developmental, in other words, like time-varying and dynamic associations over time. And so we're able to kind of get a sense, again, about that ebb and flow in symptoms and how we might predict when we might see certain increases or decreases in symptom experience. And I'll show some data on that in a second here. But before I get into that, I do want to show some of the sample. Now, this is just a snapshot. This is still an ongoing study. We're still recruiting individuals, but I wanted to at least demonstrate what we're able to do with this type of approach. So with an N of 30, which is relatively small, we were doing a cross-sectional study, but we're really interested in looking at the day-to-day experiences. We were able to collect data on 323 days. So essentially, we had 323 daily observations from 30 caregivers that allowed us to get a sense of what their day-to-day was like. And based on these caregivers, just a little bit of demographic information, we had 78% that identified as female. The mean age was 55.9 years. We had about, in this subsample, about an equal representation of white and Black African American caregivers with majority, it was additional identifying as other or more than one race. And in terms of the relationship to the individual living with dementia, the majority of our caregivers were adult children taking care of a parent living with dementia. So this data is pretty much consistent with what we see across other dementia studies in terms of demographic information. Now, this is where it gets really interesting. So when we look at daily mental health, right, and we're not asking people, to fill out a PHQ-9, we're not trying to get a diagnosis, we're just trying to get, did they experience any symptoms of depression? And what we found is that of all the days sampled, 86 individuals reported depressive symptoms, 90% reported anxiety-related symptoms, and 50% of the sample reported suicidal ideation. And so, again, we're not looking for clinically significant depression, anxiety, or suicidal ideation. We're just trying to see, are people experiencing these symptoms? And when we look at this, actually, and if I remember correctly off the top of my head, when we look at the 14 days, I would say that it was about 9 out of the 14 days, people were reporting at least one symptom of depression and anxiety. So that's really powerful in terms of how often this is occurring. Now, when we link these daily experiences to other variables of interest, we found some interesting things. So we found that higher than average stress related to, related to dementia caregiving was associated with an increased likelihood of emotional dysregulation. And so we're specifically looking at things that are stressful about caregiving, and this is really tied to managing behavioral symptoms of dementia. So when caregivers reported feeling more stressed on a given day about managing behavioral symptoms of dementia, this was associated with an increased likelihood of them reporting higher emotional dysregulation. We also found that daily social isolation significantly increased the odds of emotional dysregulation. So when individuals reported feeling more isolated than normal or than average on a given day, they were more likely to endorse or state that they experience emotional dysregulation. And then when we link this to depression-related symptoms, higher than average emotional dysregulation was linked to an increase in depression-related symptoms reported on a given day. So these findings really are starting to highlight that elevated stress and isolation can increase vulnerability to emotional challenges and psychological distress. And this is critical because we know that emotional dysregulation and we know that depression and anxiety and mental health are really key risk factors for adverse caregiving behaviors, meaning the way a person responds to a challenging behavioral symptom of dementia. Maybe they're responding in a way that is, resulting in some conflict. If a person is demonstrating care resistant behavior, maybe the caregivers engaging in some type of conflict or combative response to get a person to do some aspect of care. And so we know this is in the literature, and so being able to show on the daily level that that we're seeing these fluctuations in psychological distress and emotional dysregulation is pretty powerful and may offer some insights into how we can maybe intervene earlier before any type of harmful behavior or negative responses can occur. And we can do this when we look at things like time varying effect models. So here we modeled, and I just wanted to look specifically here in this, we're showing data from our suicidal ideation. And so, the time varying effect model really allows us to review the relationship between stressors and mental health outcome shifts over time. And so the red circle here indicates the highest suicidal ideation score across a 14-day sampling period in the first wave of data collection. And what we found is that daily suicidal ideation was significantly associated with daily depressive symptoms one day leading up to the highest suicidal ideation score. So we may have individuals that are reporting maybe suicidal ideation, on other days, but when we try to figure out when exactly that highest point is occurring, we find a significant association with depressive symptoms, essentially predicting the highest level of suicidal ideation one day prior. So this is pretty powerful to show that we can actually have some predictive ability to determine more adverse outcomes that are associated with increased stress and increased daily psychological distress, and potentially intervene earlier so things don't become much worse. We saw a similar thing with anxiety. So again, we're seeing the same thing here with the red circle indicating the highest point of suicidal ideation. And we found that daily suicidal ideation was significantly associated with daily anxiety, depressive symptoms one day leading up to the highest suicidal ideation score. So right about here, this data actually predicts when a person is about to go into a higher state of suicidal ideation. So this really does show the predictive ability of daily depression and anxiety in terms of looking at these kind of more adverse outcomes like suicidal ideation, and may provide some insight into how we're able to predict the onset of harmful behaviors such as acts of abuse and neglect. So overall, based on this study, caregiver mental health is highly dynamic with daily stressors significantly impacting well-being. And by examining these daily variations, we can gain a better understanding of how caregivers manage stress and how they might and when they might need help. So this approach highlights the importance of real-time monitoring and timely interventions to prevent mistreatment. And, to really ground this into like implications for elder mistreatment research, the findings have several implications. First, by aligning mental health screening with actual dynamic risk factors that caregivers face, we can develop more effective ways to detect mistreatment risk early. And this alignment is really essential for helping us build preventative support systems tailored to caregivers' real-time needs. And so, one approach, and I said I was going to come to this, was grounded in this idea of complex adaptive systems or dynamic systems theory, which is really based out of a lot of engineering principles. And so, the idea that with a complex system is that we can understand, using this perspective, we can understand the dynamic interactions between caregiver mental health, daily stressors, and external factors. In this model, mental health and other contextual factors essentially work together to influence mistreatment risk. So by identifying fluctuations in mental health as an early warning signal, we can predict when caregivers are most at risk and implement targeted interventions. And so one way I think about this, this really does draw on a lot of you who might be familiar with, improvement and implementation science methods. We're basically trying to look for increasing variability in the system, right? And so when we see kind of like these days where we have like these rapid peaks and valleys of depressive symptoms with, from one moment to the next, a person can have really high symptoms and then really low symptoms and so on and so forth. This increasing variability might be an early warning signal for a person that's about to shift either from casual symptom experience to severe psychopathology, or even might be an indication of somebody that might potentially engage in harmful behavior. And so, I'm really intrigued by this approach because it really helps us, develop a way to better predict when caregivers are most at risk and to implement targeted interventions. Ultimately, this model represents a comprehensive approach for presenting mistreatment by addressing the full complexity of the caregiving environment. And so one thing that we're seeing now as a need in the field is we're able to identify these early warning signals, like these patterns of increasing variation, is really trying to figure out then what contextual factors are surrounding this increasing variability. Is it the type of stress that one's experiencing? Is it the type of social support that is available or not available? Or are there other contextual factors or individual level factors that really, are driving this increasing variability? And so this will really help us pinpoint exactly when a person's, a caregiver's mental health is really going to put them at risk for either developing more severe mental health or engaging in a harmful behavior. And we're starting to explore this work in a little bit more of a larger study now, and specifically looking at social cultural factors too that might drive these experiences in diverse caregiving populations. I have an ongoing study right now that's actually looking at Hispanic and Latinx dementia caregiving experiences, where we're also looking at kind of these dynamic patterns of mental health and trying to see if we can identify these early warning signals that could potentially link in future studies to determine mental health risk. Now, there have been some studies that have come out from other teams recently that have shown a relationship between, daily depression and daily anxiety, predicting abusive and neglectful behaviors. And I think this work is going to be foundational for us to be able to think more about how we can utilize caregiver mental health, especially, variations in symptom experience as a proxy to identify potential risk for mistreatment. So, this is just a figure to kind of, just illustrate this a little bit more for a little bit more clearly. So what we can see here is, if we were to take measures of depression, let's say every day, we can get a sense of where people's scores are on a certain depression measure, and that eventually they go up. And, if we were to do correlate this with affective states like people feeling down, we can see some, as people might report more instances of feeling down, doesn't necessarily always equate to higher depression scores. But if we look at this pattern, there might be unique variations in these affective states that could potentially predict when these depression scores will go up. And we see this here. This is looking at this figure here is looking at variance. So, the variability in people reporting feeling down. And what we find is right about, time point 216 right here, we're seeing increasing variability. And if we look at that over here, this is when we start to see kind of a shift in the overall daily depression experience, and it starts to increase over time. So this increase in variability might occur earlier before people actually start reporting, more severe depression and anxiety. And so we're able to use this to maybe intervene a little bit earlier before people are actually at this heightened state. So I think it's really cool that we can use this from a predictive sense. So one practical approach of this research is really to think about using repeated mental health screening for caregivers. Regular check-ins can help detect early warning signals of mental health challenges. They may lead to mistreatment risk. So for instance, if a caregiver's mood begins to decline over a series of days, this could trigger a need for additional support so that we can mitigate potentially the risk of harmful behavior occurring. Repeated mental health screening could also offer early warnings of caregiver stress. So imagine with this type of knowledge, being able to develop a tool that prompts caregivers to check in daily on their mood and stress and provide alerts when stress reaches a high level, suggesting that resources or respite options are needed and can really help mitigate the potential for harmful behaviors occurring. Just in summary, daily tracking of caregiver mental health offers valuable insights for predicting mistreatment risk. And future research, I think, should really focus on developing tools that incorporate real-time monitoring and provide caregivers with timely support and interventions. And of course, research is needed with larger sample size, with more frequent assessment points, which is what we're kind of doing right now in our current study that is ongoing, to really understand how these patterns are looking, and not only how these patterns, what they look like, but what specific individual level factors or contextual factors might be associated with increasing variability that might be a sign of an early warning signal that we can intervene on earlier before things can intensify, either in terms of a person developing clinically significant depression and anxiety, or an individual that might engage in abusive or neglectful behaviors. And so I just wanted to share kind of my insights and some of the work that we've been doing, and kind of advocate for, these types of approaches that allow us to look at the dynamic nature of an individual's experience, especially those that are providing care to an older adult living with a chronic illness like dementia, and hopefully start to inform the field that, doing an assessment on one's needs every couple of months may not be cutting it completely, and that there's an opportunity. And I understand there's always a challenge of time and resources, but being able to track things at a more micro level can really help us, maybe prevent things earlier before they start. So I'm going to go ahead and stop there so that we have some time for question and answers, and to have a discussion here.
Thank you so much for that. That was really, really good. I see some questions. The question's about if the slides will be shared after. So this is recorded and we will post it on the website. Are you okay with us sharing the slides after? Or
Yeah, I'm fine with that.
okay, that's good. And the other question about a certificate. So we do not give out certificates for this webinar or any of the webinars. And there. Okay, there's another. Do you want me to read out the questions?
Oh,
or
I can pull up here. So I see Vanessa has a question here about how can we better support and connect caregivers to community resources and mental health resources to alleviate some of the isolation factors and risk factors that may lead to neglect or abuse when not treated. Yeah, that's a great question. And I think this is still something that we're trying to figure out in the field, right? So, one thing that always impresses me, especially in the caregiving field, and not just dementia caregiving field, we have so many interventions out there, right, that try to get at this. How do we help individuals really try to manage day-to-day stress? And so one thing that we're thinking about in terms of community resources is to really think about how we can reduce barriers to utilizing interventions or supportive services. And I hear this a lot when I'm out in the community and I'm talking to individuals, especially working with diverse dementia caregivers like Hispanic and Latinx caregivers. It is sometimes, for a variety of reasons, very hard to access resources, whether it's a lack of awareness, whether there are structural barriers, whether there are financial barriers, et cetera, health literacy barriers. We need to be more careful about how we think more methodically about how we address these barriers and find ways to get these resources and support to the community. Now, with your question specific to social isolation, this is a growing problem. And in fact, the National Institute on Aging has recognized that social isolation, not only for caregivers, for older adults, is a public health issue, and we're reaching a huge crisis here. So thinking about how we promote that in a way that doesn't cause undue stress. For example, I find with some caregivers that, when they try to engage in social interactions, sometimes that can be stressful, right? One, because people might not understand their experiences. And so I think we need a little bit more work in that space to be able to identify how to more effectively do that. So Vanessa, I hope that kind of got at your question here a little bit. Lisa, I see your question. What about caregivers not related to dementia, such as parent caring for a special needs adult child? And I think I use dementia as kind of like a base chronic condition that we're looking at. But I think we can see maybe we can apply the same theory and approaches, I think, to different populations, but the stressors might be a little bit different, and the way people access and utilize resources may look a little bit differently. But I think at the conceptual level of what we're talking about here, we can look at similar things. I don't know much about that space. I am an older adult researcher, an aging disparities researcher, but I would suspect that you could look and, monitor individuals' daily mental health experiences and kind of look at what unique contextual factors might put people at risk for experiencing, certain intense mental health, like intense depression and anxiety symptoms. Let's see. So Lori, you have a really interesting question here. So you ask, is there a time that caregivers with mental health risk should step down from caregiving, and how do you support them? And I think this is a great question, because I think, and I don't have this data here, but we actually found, and we asked this, whether or not people had a choice in caregiving. And we find that a majority of our caregivers feel like they do not have a choice, that this is a role that they're put into. And usually it's defaulted by, for example, if it's a family member, they might be the one family member that has the space, that maybe isn't working full time, that is able to do that. And so, a lot of times I think we see that a lot of individuals are put into this position and may not necessarily feel like they've had a choice in this. However, they still want to be able to provide support for a relative. And there are a lot of, whether it's personal values, et cetera, that drive an individual's desire to provide care. And so when we think about, and based on what we're seeing here, is there a time that, I don't know necessarily say it should be that people to step away from caregiving, but maybe there's a time where we can think about how we can put into place more effective resources for people, right? So they don't get to that point. And I think right now with the work that we're doing, we're trying to figure out people that are already like at the higher end of the spectrum here in terms of feeling high depression, high anxiety, that they're ready to walk away and let this all, just to be done with this. But if we're able to identify these early warning signals, we might be able to put things into place that help, one, give caregivers the resources and support they need, but then ultimately, prevent them from getting to that state of needing to walk away. I don't have a good answer in terms of like if people that are at that state, when do they walk away? But I should say that, if people are indicating before anything happens, like thoughts of harm to themselves or others, that is a clear sign that something drastic needs to happen in terms of an intervention. So, oh, hey, Karen. So you have a question here. So, you're curious about how I see building on your work to test different coping tactics for caregivers. So this is very interesting. So we're actually, I didn't have that data on this one, but we actually are collecting data on different coping strategies to see, in terms of what people are utilizing on a given day is actually effective in mitigating some of the stress and potentially decreasing the odds of depression and anxiety that we're seeing. So I don't have that exact data, but we predict that the type of coping, whether it's more adaptive coping, like problem solving, or using emotion-focused coping, like seeking social support or emotional support, or if it's, coping strategies that may not be as adaptive, like avoidance or distraction, we're trying to get a better sense on how that might actually drive some of these experiences. So that is a great question. And we're actually in the middle of collecting more data on that so we can get a better sense of how different coping strategies for caregivers might actually drive this. And in one of our studies on Hispanic and Latinx dementia caregivers, we're actually looking at how cultural factors too might drive some of these coping strategies and shape their caregiving experiences, not only in terms of how they respond to the types of stress they're experiencing, but also how this might affect the way they manage challenging behaviors, which is, the literature showing that that could be a key point in where we see these instances of abuse and neglect occurring. All right, so Shani, so you're asking, so when dealing with caregivers that experience a burnout, how should we engage from the protective side? Oftentimes in adult protective services, I experience caregivers who are offended on my presence coming to the home. I want to get the full detail without offending. Yeah, that's always a challenging thing. And I think, we find that especially one way I put this is like, not all caregivers are the same and not all caregiving experiences are the same. And so sometimes we see caregivers that are ready to say yes, this is everything that's going on. It is challenging. It is hard. We have caregivers that, we've approached for a study to say, why are you asking all this information? It's quite invasive. I don't want to talk about this. Other than really explaining that we're really trying to learn how we can best support them and learn how to best support others in their situation and not really try to frame it as anything related as a fault or that we're looking for something specific in them or what they're doing. We're just trying to see how we can get resources in place to support them is the way I approach that. Now, again, I'm coming at it from a research perspective, and I know it might be different for those of you that are coming at it from a more service perspective. And so, I think that is a tough challenge that a lot of people have on both sides. And I think, at least from the research side, what's really helped us is just really saying, we know we ask questions that may not apply to your situation. We know that we're asked questions that could be sensitive, but this is just really an opportunity for us to learn what we can do to help support you in your situation so that you are able to provide the best care for your relative. So Rebecca, your question is, do you know of if any of the caregivers are already, yes, we did have that. We did ask about baseline depression and anxiety and both pharmacological and non-pharmacological treatments. Given the low sample size, though, we did not control for that, but we are going to be including that as a covariate in our analyses for our studies that have a larger sample size. Like this study right now was just to really demonstrate that we can collect this daily variation in mental health and then potentially link it to mental health outcomes and potential behavioral outcomes down the road. But yes, that is important stuff to ask for sure, and definitely things that we're going to consider in future analyses.
Does anyone else have any questions or comments?
I think I got most of the questions that were in the chat.
Yeah, you did.
Okay.
All right, well, just give it a little bit more just in case someone's typing away. All right. If no one else has any questions, I guess we will leave it at that. Thank you so much, Dr. Puga. This was really, really good. Thank you so much.
No, yeah, no, thank you all for your time today. And like I said, I hope this gave you all some interesting insights and, showing you at least what the work that I'm doing in the research field and in the area of research of caregiver mental health and its implications for, mistreatment. And I hope to keep the conversations going. Please feel free to reach out to me. My email is out there on that slide. So if you got specific questions, I'm happy to engage in dialogue after this.
Well, have a great day, everyone. Bye.